My name is Deb Mastrolia. I am a nurse. I have a lot of certifications. I always call it the alphabet soup after my name. And all that means is that I am certified in critical care nursing, neuroscience nursing, and especially stroke nursing. All right, I've been a nurse for 43 years. Ugh, I can't even believe that. I don't know where the time has gone. And I work at Hoag Hospital. I'm the stroke nurse navigator and stroke program manager there. And I got the clicker in my pocket. And let's turn her on. And here we go. So by the end of this, I want you all to be stroke smart. All right, and it's very simple to be stroke smart. There's 3 R's. Learn how to reduce the stroke risk, which is what we're going to concentrate on first. Then how to recognize the stroke symptoms. And then what to do, how to respond if you think somebody is having a stroke. All right, but first we need to talk about what is a stroke. A stroke is a brain injury. It's caused when the blood vessel to the brain becomes either blocked or it bursts, and it cuts off all the blood flow and oxygen to the brain cells, right? So it's really about the arteries, about the pipes that feed the brain cells blood and oxygen and nutrients. Either the pipe is blocked, and that would be an ischemic stroke, and that's what most strokes are. 87% of the time, it's an ischemic stroke, a blockage in the cerebral artery. The other 13% of the time, the pipe is ruptured, the pipe is bleeding, the pipe is leaking blood either into the brain tissue or around the brain tissue itself. Now, like I said, it's all about the pipes, right? So it's all about these arteries. We've got 2 carotids that come up the front of our neck, 2 vertebrals that come up the back. They merge into this big artery here, and then they feed the front, the middle, and the back of the brain. Depending on which artery is blocked or bleeding is when you see different signs and symptoms. Because look, this is what the different parts of the brain do. So take my patient, my 50-year-old patient who came in, and he had a blockage back here in this posterior artery, right? Well, what were his symptoms? He was working from home, as we all were for a while, working on the computer, and all of a sudden he thought half of the computer screen went black, right? And he looked around, and then he realized, oh, it's not really my computer screen, it's me. This half of the world I can't see. What should I do? Oh, I should lay down and take a nap, because when I wake up, everything will be all better. Not true with stroke. You want to act fast. You want to act on it right away. So he lay down to take a nap, and then Mr. Smith couldn't sleep. So did he call 911 and have EMS come? No. He called Mrs. Smith, who came home from whatever it was she was doing, and said, Mr. Smith, I don't know what's going on, but let's get to the emergency room. And as it turns out, it was a stroke in this back artery, which was stopping him from seeing that peripheral vision, that field. And we gave him the clot buster medicine, IV TPA, and all of his vision came back. All right? Now, if you have a stroke here in the middle part, it might affect your movement, might affect your speech. So again, it's which artery and what part of the brain is affected. So what is a stroke? We were talking about what is a stroke. A stroke is a brain attack, all right? Almost 800,000 strokes will occur in the United States this year. It's the number 5 cause of death. It's the number 1 cause of adult disability. And every 4 minutes, somebody in the United States is dying from a stroke, okay? And more so over here in the southeast part of the United States as opposed to where we are here in California. So good job, California. In the United States, every 40 seconds, somebody's having a stroke. But 80% of strokes are preventable. Certain risk factors, including your hereditary, so your genes, your age, and your race, can't be changed. But there are many things that can be changed, treated, or controlled. So that's what we're going to talk about now, is your stroke risk. Age. Unfortunately, the older we get, the more our risk of having a stroke goes up. And there's nothing we can do about that except make sure that we stay active and take care of all the other risk factors. Family history. So if you have a family history of having a stroke, a parent, a grandparent, a sister or brother, especially if they had the stroke before age 65, that increases your chance of having a stroke, okay? And race makes a difference. Statistics show that African Americans have a much higher risk of death from stroke, and Hispanics and Latinos also have some increased risks for stroke. Gender also affects your risk for stroke, and women tend to have more strokes than men, okay? Every year, stroke kills more women than men. About 55,000 more women die from a stroke each year. And stroke kills twice as many women. It's really hard to speak and have this mask on, I'm sorry. Well, I don't want to break the rules, so I want to be able to come back. Stroke kills twice as many women as breast cancer does every year. So we all know about Breast Cancer Awareness Month, right? We all know that breast cancer awareness has a color, right? Pink, right? And I think it's the month of October, right? Did you all know that right now, May is Stroke Awareness Month? Nope. Do we have a color? Nope. So we have more work to do about getting awareness out there. So I'm glad you're all here. We have plenty of giveaways for you. I'll show you those in a few minutes. I want you to take them home with you and share them with your friends and family, okay? Because we need to increase stroke awareness. If you've had a stroke or a TIA or a heart attack in the past, that also can increase your risk of having a stroke, all right? And these are things that we can't really do anything about. So let's focus on the things we can do something about, all right? What is the #1 cause of stroke? Anybody know? High blood pressure, hypertension. Is that something you can control? You can work real hard at it, right? You can work hard at it with diet and exercise and medication. So you really want to manage your blood pressure. When it stays in a healthy range, it reduces the strain on your heart, your arteries, your kidneys, and that all keeps you healthy longer. Normal blood pressure is 120/80. So in 2017, they came out with new guidelines, and we've pretty much stuck with these. Again, 120/80 is considered normal. Anything higher with the top number is considered elevated, and then you start getting into your high blood pressure stage 1 or stage 2, okay? And when you get into these, that's when you really need to start considering taking blood pressure medicine. Does everyone in this room know what their blood pressure usually is? Okay, good. How many people in this room have a blood pressure machine at home? Okay, so you want to make sure that you're doing the right things when you sit down and take your blood pressure to make sure that the number that you're looking at is accurate. So at your next doctor's appointment, if you're going into the office for your doctor's appointment and it's not a telemedicine appointment, bring your blood pressure machine with you, all right? When they check your blood pressure in the office, check it with your machine and make sure that the two numbers match, okay? So before you take your blood pressure, what do you want to do? Well, don't be smoking. Don't have a big old cup of Starbucks. Don't have been exercising for about 30 minutes prior to checking your blood pressure. Okay? And what else do they have here? Oh, and sit still for about 5 minutes. Just try and rest, relax, take some deep breaths. All right? Then you push the button and it's going to take your blood pressure. You want to make sure you have the cuff on the right way and it's not too big and it's not too small for your arm because that'll give you some false readings. All right, keep your arm out straight and on a flat surface. Sit up straight, your feet on the floor, don't talk, and check your blood pressure. All right? What happens when it's not the number you want to see? What do you do? press the button again, right? Okay, so wait at least a minute before you check it again, all right? Again, take some deep breaths, make sure the cuff's on right. Go ahead and check it again. American Heart Association recommends that you can do it up to 3 times and then take the average of the 3 readings. Okay. What I would suggest is that if you're getting higher numbers than you want to see, that you wait a while, come back and check it again. And then that you start keeping maybe a diary of what your blood pressure is. Check it again in the evening, all right? And see what the trend is. That's what your doctor wants to know. They don't want to know about one-time blood pressure that was high. They want to know what's the trend day after day, okay? So that's what we want to do for our blood pressure. Diabetes. Having diabetes more than doubles one's risk of stroke, all right? A lot of people, when they have diabetes, they also have high blood pressure, high blood cholesterol, they're overweight, and so all of these things increase the risk even more. People with diabetes, almost every 2 minutes in the United States, somebody is being hospitalized for a stroke. So we really want to keep those blood sugars under control. Keep your diabetes under control. Work with your doctor. It's not easy, but it can be done. High blood cholesterol. All right, does everybody know what their cholesterol levels are? Okay, I see some nodding heads. All right. When you get your lab results, if you don't go on computer, my mom, she uses the internet to send an email every Sunday. She sends her newsletter out to all the family, but she does not go on the internet to check her health records or communicate with her doctor. She picks up the phone and talks with them. So for those of you who don't use the patient portals, go ahead and get a copy of your lab results, all right? They're your lab results. You should know what they are. Get a copy, make sure you know what they are, and then this way you can trend them, especially if you started out with a high cholesterol and now you're changing your diet and your exercise or maybe taking a statin to reduce that. Make sure that you have those results and you see how they trend over the next year. So diet. I love those pictures because everything that you do to eat a heart-healthy diet is also a brain-healthy diet, okay? It's about the arteries in your heart, the arteries in your brain, the arteries in the rest of your body. So eat foods that improve your heart and brain health. Again, this means diets that are low in saturated fat, that don't have trans fat, and don't have a lot of cholesterol, so that we keep your cholesterol levels down. Your complete total cholesterol along with your LDL. Any diet high in salt, of course, increases blood pressure. High calorie diets, of course, will just lead to extra added weight. And so you want to eat the vitamin-rich fruits and veggies because they really help improve your brain function. A lot of people ask me, well, what's the best diet to follow, especially for brain health? Anybody have an idea? A vegetarian. The Mediterranean diet. All right, have you heard of that? Lean meats, fish, fruits, veggies, and if you have to use oil, olive oil, okay? And that really is good for brain function, along with your cholesterol levels and your heart health. So look into the Mediterranean diet if you're looking to follow something, some specific diet. The weather is getting nice. People are getting vaccinated. CDC says we can take our masks off outside. Get outside, get some activity, get some physical activity, right? Physical inactivity, so not moving around, increases your risk of stroke, of heart disease, of becoming overweight, developing high blood pressure, high cholesterol, and diabetes. So go ahead and get out there, okay? Meet up with a friend, socially distance, take a walk. We all need it. We all need to get out there again. Maintain a healthy weight. Okay, if you're overweight, take steps to get your body mass into a healthy range. I think we've all, or a lot of myself and my colleagues, have put on some weight during COVID lockdown. Let's get back out there and get back in shape. Tobacco. Don't use tobacco. Plain and simple. Smoking, vaping, chewing. The nicotine is really a vasoconstrictor, so it damages those blood vessels, which in turn gives you heart disease, gives you brain disease, all right? And when you smoke a cigarette, it also includes some carbon monoxide, which also works to damage the blood vessels. So lots of research out there about how tobacco just is not good for us. Atrial fibrillation. How many of you have heard of atrial fibrillation? Okay. Atrial fibrillation is basically your heart has 4 chambers, right? 2 chambers on top, 2 chambers on the bottom. The top are the atria, the bottom are the ventricles. When the ventricles fibrillate, when they don't have an organized pump, when the ventricles fibrillate, what's a code blue? That's a call 911. That's a patient who has no pulse. When the top atria, when those chambers fibrillate, that's not a code blue. All right, some people feel dizzy with it. Some people feel palpitations and flutters. But what it does is we don't get a good squish of that blood chamber to move it into the next chamber. And so the blood stagnates there, and it can form little clots. All right? And then maybe you get a good pump, and off go those clots, and if it goes up to the brain, now you can have a stroke. All right? So that's a neuronurse's explanation of a heart problem, of atrial fibrillation. All right? If you have atrial fibrillation, it increases your risk of stroke by 5 times. The fluttering in the heart may cause blood to pool and clot, as I said, and then those clots go up to the brain. So if you do have atrial fibrillation, you really have to work with your doctor to see whether or not anticoagulation is what you need to do, all right? And that is Coumadin or warfarin, and you see all the commercials on TV for non-valvular atrial fib, and they talk about Eliquis and Xarelto and Pradaxa. They're all anticoagulants. They stop you from making clots. Okay, so atrial fibrillation, most patients need to go on anticoagulation unless they have other risk factors for atrial fibrillation. Carotid artery disease. So this is a good picture, right? Our carotids there, and here's a person with high cholesterol levels, okay, and all that atherosclerosis, plaque starts building up. And then let's say you get a little dehydrated and the platelets in your blood start clumping together and then they form a blockage here. And now that whole half of my brain is at risk for a stroke. So carotid artery disease, if you do have atherosclerosis, you'd be working with your doctor, making sure that you're on the right medications, getting carotid ultrasounds, seeing whether or not you qualify and need surgery, a carotid endarterectomy, or a carotid stent. All right, but we want to make sure that we take care of these things. And staying hydrated. I talked a little bit about, you know, if you get dehydrated and then the platelets get sticky and stick together and form clots in your blood. So you have to stay hydrated, and you have to stay hydrated with water, all right? When you're drinking caffeinated beverages, coffee or tea or colas with caffeine in them, caffeine dehydrates you. Caffeine's a diuretic. So it's okay. You don't want to talk to me if I haven't had my cup of coffee in the morning, right? It's okay to have some caffeine, but you really need to make sure that you're drinking enough water, and especially as the weather gets warmer, okay? Staying hydrated, getting dehydrated can be a risk factor for stroke. And we see our stroke patient numbers go up when we have heat waves, all right? Because people are getting dehydrated. And you can't hydrate with alcoholic beverages, right? According to US dietary guidelines, people should limit their alcohol intake, meaning 1 serving of alcohol per day for women and up to 2 servings per day for men. All right, and 1 serving is considered 1 12-ounce beer, 1 5-ounce glass of wine, and 1.5 ounce of liquor. Questions? Sleep. Don't you feel good when you've had a good night's rest? Yeah, I just got a new mattress. Hallelujah, I love it. Restorative sleep. Make sure you're getting enough sleep, all right? It benefits your whole body, including your heart and brain. It makes us all in a better mood. Your memory seems better, your reasoning seems better. So make sure that you're setting aside time to get a good night's sleep. Now, some people have breathing issues as they lay down to go to sleep, and they never really seem to get enough rest, right? Sleep apnea, obstructive sleep apnea. That's the person who snores. I can't do it good with my mask on, but snores, and then all of a sudden there's this period of silence. And that period of silence could be 30 seconds, 45 seconds, even up to a minute. And in that time frame, there's no breathing going on. There's no oxygen going to the brain, so it increases your chance of having a stroke or a heart attack. Hoag has an excellent sleep center. All right, if you've been told that you have sleep apnea, obstructive sleep apnea, you want to get a referral to a sleep center and get your sleep test done and see if indeed you are having sleep apnea. And I liked this, I copied this. Sleep apnea hurts hearts. It increases the risk of heart failure, of high blood pressure, elevated blood pressure, of atrial fib, of resistant hypertension, of type 2 diabetes, and stroke. So hashtag snored to death.
What's the recommended number of hours that you get per night?
That's a good question. I always go with like the 8 hours, but I know it can vary. And as you get older, you might not need as many as 8 hours, and some people might need more. So I don't have a good answer for you. I would say around 8. But then again, I know plenty of people who survive on, 5 to 6 hours of sleep a night, and they're just fine with that. So I think it's a little bit of case by case, not too much, not too little. Oops, demolishing my markers here. So remember, 80% of strokes can be prevented by controlling those risk factors. That's not too hard to do, is it? No. 80% of strokes can be prevented if you control and manage those risk factors. So make sure that you're communicating with your doctor. I know a lot of people tried to stay away from their doctors when we were in COVID lockdown, but remember, we can now get into the office with masks on. We can do telemedicine, on our phones, on our computers, on our tablets. So make sure that you're getting out there and getting the checkups that you need. We have a stroke risk scorecard in the back, so please stop by the table and take one home with you. It'll help you calculate if you have any risk for having a stroke. If you do come up in the red zone and it looks like you're at high risk, don't freak out, okay? Because then you might have a stroke. Take this, schedule a doctor's appointment, take this with you and go over what your risk factors are and what you can do to manage them, all right? All right, so do you feel like you're getting stroke smart? Good. Do I feel like I'm getting a hot flash? Yeah. Whew. Okay, next we're going to talk about the second R, recognize stroke symptoms. Okay, we used to teach FAST, F-A-S-T. Now we teach Be Fast, because we realized there's about 10% of strokes that we were missing that went to the posterior circulation back there. So the B stands for balance, a sudden loss of balance. Eyes, a sudden loss of vision. Face, all of a sudden the face droops. A is for arm, all of a sudden the arm is weak. S is for speech, all of a sudden the speech is slurred. T is for time to call 911. So again, just to go through it again, because it's so important. B is for balance. All right, all of a sudden your walk is off. Your arms, like when you try and do that, you know, nose to finger to nose kind of thing, your arms all over the place. A loss of balance and coordination. Eyes, a sudden loss of eyes in one eye, both eye, or all of a sudden you're seeing double. All right, that's a sudden vision change. And that's the key with all of these, that this is a sudden change. Not like, oh, I need new glasses, my vision's getting blurrier and blurrier. It's no, 1 minute you're normal, next minute you're not. Face, all of a sudden does one side of the face droop. So ask the person, Deb, smile. Take your mask off and smile for me. And if both sides go up evenly, great. If all of a sudden one side is drooping and it wasn't that way before, then we have a problem. Then we need to call 911 and get right into the emergency room. A is for arm. So if somebody starts complaining of a weak or numb arm, again, arms up. And if one arm falls down and it wasn't that way before, then we have a problem. We need to get into the emergency room and get an evaluation. Speech. All right, all of a sudden it's slurred, or no words come out at all, or they come out and they make no sense at all. All right, ask the person to repeat a simple sentence, like it's a sunny day, or whatever you want to ask them to repeat. We usually say, repeat, it's a sunny day. If they can do it correctly, good. If not, that could be a stroke. You really do need to get in and get evaluated. And T is for time. All right, time to call 911. Also time to start thinking about, when did I last see that person normal? All right? When was Deb not slurring her words? Was it 5 minutes ago? And the EMS is going to ask you, well, what's 5 minutes ago? I don't have a clock here, but whatever time it is, that would be the time you tell them, okay? So T is for time to call 911 and time to think about, what time did I last see that person normal? Let's talk about a TIA. Does anybody know what a TIA is? Transient ischemic attack, okay? I'm standing here, all of a sudden I drop the mic, my face starts drooping, I go to walk, my leg starts dragging. It's the right side of my body that's affected, so it's probably a stroke happening in the left side. Sorry, I didn't mean to move out of my space. And then you call 911, because it looks like Deb's having a stroke. You lay me down on the ground. All right, so that increases blood flow up to the brain. You open up the door if you were at home so that EMS can get right in and get me. And then by the time EMS comes, I stand up, I'm talking fine, I'm walking fine, my smile is back to normal, everything's fine. That could be a TIA, a transient ischemic attack. I had a little blood clot up here, my body was able to break it down on its own. Everything went back to normal. If you did a CAT scan or an MRI, you would see no brain damage at all. That was a transient ischemic attack. So would the paramedics say, okay, Deb, just continue your lecture and you're fine, then go home and get some rest? No. They would pack me up and take me over to the hospital. All right, because we want to get into the hospital, we want to do the full workup and figure out, why did I have that transient ischemic attack? Why did I have those symptoms for that short while? Is it high blood pressure? Is it high cholesterol? Do I have atrial fib? Am I snoring when I sleep at night and having sleep apnea? What's going on? What's causing the stroke? So we'll do the full workup, usually in one overnight stay, and we'll let you go in the morning after we've got things figured out. All right? TIA, it's important that you seek medical care if you know of someone who's had a TIA. So I say, that's your red flag, all right? That's your warning. So remember, the sooner a stroke patient gets to the hospital, the sooner they get life-saving treatment. Every 4 minutes, somebody's dying of a stroke, so we all have to be fast. This slide, stroke and COVID. So in a lot of the live streams that I did over the past year, we really talked about how fearful people were to come into the hospital, even if they were having strokes and heart attacks, and they stayed home. Many of them stayed home. And then they came in the next day when all of a sudden they couldn't move the whole side of their body. And by then it was too late for us to really give them any of these life-saving treatments. We were still able to hospitalize them and help them and get them rehab, but we couldn't give them any of the clot buster medicine or do any of the other interventions because it was outside of the time window. So we really encouraged people, even though COVID was happening, there was a lot of screening that went on, and the hospital was still a safe place. All right, I'm here to tell you that probably 6 months ago, we had a little counter in the corner of our computer at Hoag, and we had a lot of COVID patients. It told us how many COVID patients there were in the hospital. Some days there were over 200. And I think yesterday when I looked, we had 1. Okay, so keep doing what you're doing, masks, social distance. No matter how hot they get, do what you gotta do to stay safe. And if you are experiencing stroke symptoms or someone you know is, call 911 and get right in. So what happens when EMS gets there? Well, again, you're gonna have been thinking about, when did I last see that person normal? Because they need to know that, all right? They need to know that time. Tell them what medications the person is on, all right? And especially if they're on any of those anticoagulants, all right? And then give them the cell phone number of a family member or your cell phone number, because when they get to the hospital, the doctor's gonna wanna ask some more questions, and they're gonna need to talk to some family member. The right care, right away, makes all the difference. It can save a life, and most importantly, it saves the quality of life, okay? Saves the quality of life. It allows people to talk and communicate with their loved ones, all right? To get up and walk and not have to be confined to a bed on bed rest. So call 911 to get transported quickly to a stroke certified hospital. Hoag Hospital is a certified stroke center with the county and with DNV, an accrediting agency, and we have all the Gold Plus awards with American Heart, American Stroke Association for Get With The Guidelines. Our patients do very well. What happens when you get to Hoag? Well, the first thing we want to do is EMS will stop you right in the hallway. The doctor, the nurses, a whole swarm of people will rush to your side, ask a bunch of questions, do an assessment, and get you off to do a CAT scan. All right, we want to get you to CAT scan within 20 minutes or less, and our average time is about 11 minutes. Get you back to CAT scan and take a look at that CAT scan. This is a person who's having an ischemic stroke, all right, and this green here is telling me all of these brain cells are at risk. If we don't get blood flow reestablished, those brain cells are going to die, and that person's going to have a massive stroke. This patient, when we did their CAT scan, we saw this bright white spot. That's a big pocket of blood. This patient's having a hemorrhagic stroke, so the treatment's going to be much different. Time is brain, that's our mantra. So the person who's having an ischemic stroke or the clot in the brain artery, they're going to either get a clot busting medication, TPA, tissue plasminogen activator, or maybe they meet criteria for the clot removing device, stent retrievers and suction catheters, and I have pictures of those. If it's a hemorrhagic stroke, so the artery is bleeding into the brain, it's subarachnoid hemorrhage, about 3% of the time, that's what it is. That patient might have to get an aneurysm coiling or clipping. If it's the ICH kind, then for the most part, we're going to control blood pressure and possible neurosurgery. Depends on how big the bleed is. So for these hemorrhagic strokes, this subarachnoid hemorrhage that I talked about first, you can see here, it's an aneurysm, a ballooning in the wall, and it bleeds into the subarachnoid space. So all the blood is in the CSF that surrounds the brain. These patients are very, very sick, and these are the ones that have the worst headache of their life, okay? So they can be treated with coils. What we want to do is get rid of that aneurysm so it can't bleed anymore. So they can be treated with coils, with some of these flow diverter kind of stents, or possibly neurosurgery, where they go in and they actually put a clip on that aneurysm. If it's an ICH, so about 10% of the time, now the artery is bleeding into the brain tissue itself. This is what we saw the CAT scan of, that big pocket of blood, okay? And these patients might have neurosurgery, might not. It just depends on how they're doing and how big of an area that bleeding is. But what's the number one cause of both of these types of bleeds? High blood pressure. High blood pressure, especially for this one. Stimulant use will make these aneurysms bleed. So those energy drinks, not so good for you. But let's talk about the strokes that we see more often, right? The ischemic stroke. 87% of the time, it's that ischemic stroke, that clot in the brain artery. We need to know the last time seen normal, or the last known well, all right? Once we establish that time, let's say it was at 1:15 when I walked into this room. That was the last time anybody saw me well because my mask was off and I was chit-chatting in the back. All right, so 1:15. From 0 to 4.5 hours from that time, patient can be given the clot-dissolving IV medication, IV Alteplase. All right, so if it was 1:15, that would be what? 5:45. Up until 5:45, if I met the criteria and was having a stroke, I could get IV Alteplase. Out to 24 hours, if it was what we call a large vessel occlusion, and I'm going to show you that, I could possibly have a procedure done to remove that clot. All right, so let's talk about the IV Alteplase. The nurse mixes it up, the physicians are there, it runs in an IV over an hour, and it breaks up all the clots in your body, including the one up in your brain. So if you've had major surgery or recent trauma, then we couldn't give you the clot buster medicine, right? Because you would bleed everywhere, right? So you have to meet certain criteria in order to get the clot buster medicine. But like I said, it runs in over an hour, and then for the next 24 hours, we watch you in the ICU. And again, you know, I've seen people coming in that couldn't talk, couldn't swallow, get IV Alteplase, and their speech comes back. For some people, it comes back in 1 or 2 hours. For some, maybe 2 or 3 days. And for some, maybe 2 or 3 months. But getting the IV Alteplase in really helps to break up that clot, which gets blood and oxygen back to those brain cells, and they can do very well. But what if it's a big clot? Sometimes patients come in, we think of a clot as like a tiny little clot, right? Sometimes they come in and they have clots that are about this long, okay? And they're in these large vessels, right? So what we need to do then is give the IV TPA if they meet criteria, and then up to 24 hours from when they were last seen normal, maybe we can do this procedure where we go in there and actively pull the clot out. And I say we, and I don't do that. Very skilled physicians do that, not me. I stand back and I watch them.
Is that by the heart?
Well, that's what I'm going to show you here. So it's just like a heart cath. Okay, they go in through the femoral artery, and then this catheter feeds all the way up past the heart. This picture's kind of funny. It looks like it's going through it. It doesn't go through it. It's in the vessel behind it. And it goes all the way up to the brain, right where that clot is. There are stent retrievers, so you can see kind of a wire mesh that will then pull that clot out. So here's a patient. They had, under fluoroscopy, they had contrast injected, and this is what the normal side looks like, right? But this is where the clot was, so no blood flow to that whole half of the brain. All right, this is looking at the brain this side like that. They went ahead and pulled that clot out with the stent retriever. And then look, we've got all that blood flow back. That's a patient who's going to go on to be back to normal after procedure, as opposed to someone who couldn't swallow and talk and walk and all of those things. There's also another procedure, the same approach, going through the femoral artery and going all the way up to that brain clot. And then once they get up there, they kind of poke at the clot and turn on this suction machine, and it's like a vacuum. It vacuums out the clot. Same kind of thing, all right? The clot's removed, blood flow's restored, blood, oxygen, nutrients are getting up to those brain cells. The person went from not walking, not talking, paralyzed on one side, to completely back to normal. It's like a miracle, it really is. But we can only perform miracles if you get to the hospital quickly, right? So that's why it's so important to call 911 and get right in so we can do a CAT scan, figure out what kind of stroke it is, and then give you the right treatment. So remember, stroke is a brain attack. It's often preventable and treatable. You know the 3 R's. You know be fast. So you are all stroke experts now, right? Questions? Yeah.
If a person snores, does that mean that they definitely have sleep apnea, or could you be a snorer and not? You could.
Right. Just because you snore doesn't mean that you have those periods where you're not breathing. All right. And there's different kinds of apnea also. So that's why it's important to talk with your doctor about it and then get the right workup. Because not every snoring person needs to have CPAP. Yeah.
I had an ocular migraine. I didn't know what it caused it.
Ocular migraine. So migraines are a vascular phenomenon up in the brain, and they can present with stroke-like symptoms, right? And you don't know if it's a stroke or if it's a migraine. That's why you really have to, especially for the first 1 or 2 that you have to get in, get the full workup, and then get the diagnosis. Okay, we think these are migraines, and then you can continue to work on what you need to do to control those migraines. But yeah, migraines can present in a lot of different ways. We see patients who come in and they really, they're having a little bit of a facial droop and their speech is off, and it ends up being a migraine. But you got to have that full workup before you can say, okay, this is a migraine. Because if it's a stroke, I want to be able to treat you for the stroke appropriately. So, yeah.
Why do they always do a CT scan instead of an MRI?
Okay, so when you're coming in with an acute stroke, why are we going to do a CT scan rather than an MRI? Good question. Some hospitals do have an MRI protocol, and it's just a quick and fast MRI. Most hospitals use CT scan because you can get results within a matter of minutes. You're into the scanner, 2 minutes, you've got your non-contrast CT, you know if there's blood in the brain or not, then you can inject contrast and do some of the perfusion imaging, look at the arteries, and so within a matter of minutes, you have all of this information at your fingertips to make treatment decisions. When we do CAT scan, we get those immediate results, and the perfusion imaging is what tells us remember when I showed you that green, shows you that those are the cells at risk. We look at that, and then we look at the patient and their symptoms, and sometimes we have a patient who's got negative CAT scan imaging, but their symptoms are that of a stroke, okay? They're not moving their side, right? And then they will get IV TPA. They'll get treated with that if appropriate. What happens is if the symptoms are mild and the decision is not to give TPA for whatever reasons, the timing maybe, I'm not sure. Then we do an MRI as follow-up because the CAT scan didn't show the stroke. Now we want to do more looking at the tissue, and it gives us a better picture, and then we see those tiny little strokes. So the CAT scan is always the imaging of choice for us at first because it gives you a quick and easy, as opposed to the MRI you sit through, takes a while. Okay? What else? Yes, sir.
Can strokes be caused by side effects from other medications?
Can strokes be caused by side effects from other medications? I would say no, but it depends on what medication you're referring to. I would have to look into it, but it's not usually the side effect of another medication that I'm aware of. Did that kind of answer your question? Anybody else? Yes?
Do all stroke patients end up on blood thinners?
Blood thinners like an aspirin?
Like Plavix, aspirin?
Right. Yes. If you've had an ischemic stroke, unless there's a contraindication, the research shows that you would be on an antiplatelet. So that would be an aspirin. If it's an aspirin fail, then we might look to Plavix, clopidogrel. There's some other ones out on the market, Agrinox. But yes, the antiplatelet has been proven to help from getting those platelets sticking together, forming the clot, and having another stroke or heart attack.
For life.
For life.
And how can you tell if it's a stroke that's caused by the heart or by the brain? Carotid.
So how can you tell if the stroke was caused by the heart or by carotid disease? By the workup that's done, okay? By carotid ultrasounds would tell you if there's carotid plaque and issues or stenosis, okay? The heart monitor would tell you if there's any arrhythmias, atrial fib, that kind of thing.
Have you seen cases where neither one shows that?
Yes, I have. And again, looking at the type of stroke, when you look at the CAT scans, the physicians can tell if it looks like it's due to a cardiac embolus. Quite often it's a clot lodged in an artery, so it's more of a wedge shape stroke. Or sometimes we see a showering of little clots, little strokes, and then they think, yeah, this probably could be a cardiac event. And that's when they would recommend, say, 30-day outpatient heart monitoring. So again, looking at the brain imaging, putting all the pieces together of the workup. But then again, up to 7% of strokes are what we call cryptogenic. And that means we really don't know why they happened. Okay? We just did our due diligence. We did all the workup. You know, we did blood tests for any hypercoagulability. We did the ultrasound of the heart, looking to see if there's any shunts. You know, we looked at everything, and there really is no conclusive reason. Yes?
If a person has a regular physical, like a yearly physical,
Mm-hmm.
would there be things the doctor would find in that physical that could give you a clue?
Yes. It would be all those things that we talked about, all of those risk factors, right? The doctor would be doing a thorough physical, asking questions, doing blood work, and then from all of those, identify any risks and then kind of take it from there. And then there's things, like we said, that you do yourself personally, making sure you get enough rest, that you're staying hydrated, physically active, socially active, all of those things. Okay. All right, good questions, guys. Well, thank you for coming out.
Thank you.
Well, thank you. Well, thank you. you.
You're welcome.